Welcome, guys, to our first ever The Birth Network educational series. This will be something that occurs monthly, and we will record all of the sessions. So if you are not able to make it, we will have it posted either on our website or on YouTube. And then I'll hand it over to Kristen. She can tell you a little bit about the Birth Network, what it is, and
Yes, so the Birth Network was inspired by some of our own experiences in trying to navigate through pregnancy, postpartum, labor, and delivery education, and not really knowing what resources to use, where to go to get all the information that we would need that would help us have empowered and educated birthing experiences. So Moms Advocating for Moms Alliance created the idea of the Birth Network, where we do have monthly educational series where we talk about different topics every month and include guest speakers from all over the maternal health care field, such as OBGYNs, CNMs, CPMs, perinatal mental health specialists, to come in and bring evidence-based information right to you. So you're not having to rifle through the millions and millions and millions of gigabytes of data that's available online pertaining to pregnancy, birth, and postpartum.
Perfect. All right, and then I think we're going to cover 3 topics today. The first is it'll be just an overview, because a lot of our sessions will go a little more in depth of these topics. So the 3 things we'll cover today will be just the different providers that's available to you, when you should be transferred or why you should be transferred. Jamie will cover that, and then Kristen will cover preparing for pregnancy and birth and things that you can do to get prepared for that. So
I was hoping when I joined the Mamas group, there's so much information out there that's either very, very far on the medical extreme and anti-natural birth, out-of-hospital birth, and then there's so much stuff on the out-of-hospital side that's very anti-medical, anti-hospital. And so our hope with the Birth Network is to bring more balance to that. Not that one is right and one is wrong, or that people shouldn't birth in one place and should birth in the other, but just a cohesive model of care where if you start out of hospital and you end up in hospital, it's not scary. If you start in hospital, you're not anti everything out of hospital, and you understand that there's a spectrum of providers that each have a place in working together.
Perfect. Okay, I guess we can start with the foundations of pregnancy, and then...
Absolutely. So I'm going to talk about mental preparedness and how to prepare for an empowered birth. And so some of the main components for preparing for an empowered and informed birth are going to be through education. So what does education mean? As I said, there is so much information available to us online through various different sources. It can be very difficult for the average consumer to be able to pinpoint what is evidence-based and what is misinformation, what is right for me in my personal health history versus what is right for my friend Sally Jane down the street. So when we talk about education, when you become pregnant, it is up to you to take ownership of your birthing experience, and also your partner as well. The more that you know, the more agency that you have over this process. Birth is one of the most information-saturated topics online, from TikTok, social media influencers, to podcasts, parenting blogs, and then guidelines from major institutions like ACOG, A1, and the International Confederation of Midwives. Knowing how to separate evidence-based information versus fear-based bias messaging helps parents make confident and informed decisions. So what are reputable sources? Reputable sources are often characterized by rigorous scientific methodology, transparency, and a lack of conflicts of interest. These sources are grounded in current research and not just personal opinion. Online, this can consist of ACOG, WHO, Evidence-Based Birth, Lamaze, and March of Dimes. Now, there are more reputable resources, but these are just some of the major ones that we will be familiar with within the United States. Another important addition here is when we discuss education and evidence-based, what is evidence-based birth? So evidence-based was coined in the 1980s to 1990s and sits on about 3 pegs. That is access to high quality evidence and research paired with a qualified and experienced provider. And the third leg, that's one of the most important legs in evidence-based care, is considering the patient's values and needs in their individual health experiences. So, for example, I've been binging the Evidence-Based Birth podcast, which I absolutely love. I've been talking about it nonstop for like 4 days, and where she discusses a certain provider who in the 1950s did manual placental removal for one of his patients, and then said, this worked for me, and subsequently did that for all of his patients based on his own provider opinion and not based on scientific research, telling him whether or not this was a good option for all of his patients, or even if this was a safe option, without recording the outcomes or comparing these outcomes to patients who did not have manual placental removal during every birthing process. So now we're going to move forward to education transparency when looking at online resources considering these factors. So let's say we're looking at a social media blog or an influencer, looking at their credentials and understanding the education behind the credentials. For example, doulas will not be giving medical advice. Low-risk providers won't be giving advice or treating for high-risk conditions. And the same can be true for a pediatrician not giving advice on high-risk conditions or obstetric-based care. Disclosure of sponsorships or affiliations. So if you have a social media influencer that's like, oh, well, these prenatal vitamins are bad, but try these that I'm using, and here's my affiliate code. That lets you know that there's some sort of monetary bias that is pushing that influencer to get you to buy the product that they are selling, and that is not technically based in evidence or research and what is best for your personal health. Inclusivity and respect. Good resources recognize diverse groups, families, and birthing experiences, represents different cultural and medical realities, avoids judgment or undermining of birth choices, home versus hospital, medicated versus unmedicated. Balanced perspectives is really important here, avoiding all good or all bad narratives. Examples of this kind of language will be all doctors are just medically minded and trained to cut, or all midwives don't value medical science-backed interventions, or any home birth mom is not looking at the best interest of her and her baby. If you use an epidural, you're exposing your baby to drugs and will have parenting issues. All interventions are bad, or your body was built to birth. I would like to say that I am a walking, talking testament. Sometimes bodies are do not do what they are designed to do. In my first pregnancy, I developed preeclampsia in my 3rd trimester. My son did not know what he was supposed to be doing because he was laying like a banana in my uterus. And
Did you say he was laying like a banana?
He was laying like a banana in my uterus.
Transverse positioning.
Yes. And if you don't know, your baby is supposed to be facing like head down, right? Like is the face supposed to be facing towards the back or the front? Yes.
Most babies start out labor facing towards the hip, and then they rotate throughout labor to face towards the back.
Yes, their head turns as they descend. Anyway, my son didn't do that. So I'm a perfect example that sometimes bodies just they don't do what they are quote unquote supposed to do. So it's really important to be in tune with what's going on in your body and also have a trusting relationship with the provider that also recognizes the signs that, hey, maybe things aren't going the way that they should, even though most of the time it does. Let's see. Good resources will neutrally outline the benefits and known risks to all options without personal opinion. So without saying things, if you choose this intervention or you choose not to do this intervention, something bad is going to happen to you, or you're not a good parent, or there's no judgment implying that if you do not do what your provider tells you to do, that something will happen to you. So red flags and resources. No sources or outdated data. Studies show, but no citations or cherry picking certain language from studies to sway a narrative. So when we're looking at studies, instead of taking the whole study and the conclusion of the study as well as the population that was being observed, taking little bits and pieces of that data and using that to persuade you into whatever narrative that person or provider is, trying to coerce you into. So fear or shame tactics are another red flag in resources or even providers. If you don't do this, your baby will. If you birth there, then you will. One fits all kind of advice is also not a great way to an empowered birth. There's the title of a book that I want to read called Babies Are Not Pizzas. They are born and not delivered. Birth is not a conveyor belt. There's no single policy that is going to work for everybody. It is an individual and tailored experience based off, again, your own personal medical and health needs.
I think we, as a group as well, have had a vested interest in data and statistics, because a lot of what Kristen is saying with information and research that is presented to consumers doesn't necessarily come from models of care that we have here. A lot of them are in other countries, and it does show that midwifery is safe, but the overwhelming reason why are the transport arrangements and the collaboration and the systemic model of care that they have, which we are working on here, but it's not set up the same as it is in other countries. So I think a lot of it, I'm sure y'all know, well, I know that you know, smooth transitions and the data collection, CBDR, PDR, are all things in the United States that are used to collect data and statistics, but we're not required to do that here in Texas. So we're working on trying to implement that so that we can show, yes, this is safe, here's what needs to be changed, and work on collaborative relationships with good transfer agreements so that it is safer for moms and babies.
Yeah, and I think data and reporting, especially on the specific model of care that is inhabited in out-of-hospital settings, will be very beneficial to in-hospital settings as well. Because when we're in hospitals, we often run into policies that are enforced by admin or a board of people that are not actually experiencing what the birthing person is experiencing. And so showing what works in out-of-hospital settings, low interventions, or tailorizing the experience to the person instead of using policies to dictate birth, I think could also improve in-hospital statistics as well.
For sure.
So I think this is a really important topic as well, and something that I've really tried to come to terms with in the last couple of years, but understanding your own biases. So there's this book.
Kristen reads a lot.
we all read a lot. Listen, I haven't read this book yet, okay? Like 3 of the books that I've mentioned today, I have not had the pleasure of reading. But it's called, I believe, The Medical Mind, where it's written by a doctor and someone else. I'm sorry, I don't know who the someone else is. And they specifically speak about how to navigate through making the best medical choices for you, but first by understanding like who you are within the medical system, right? Are you somebody who is a medical maximist or minimalist, or a naturalist, or someone who really enjoys like that maximum intervention and technology, and that's what makes you feel safe? Understanding if you, when you're presented with medical advice, are you a natural skeptic, or are you more trusting of whatever your provider is going to tell you? And so understanding your own biases will help you have more authentic relationships with your providers and with yourself, and understanding that birth is not a science. Pregnancy is not a complete science. And the one thing that is most predictable about birth is that it is unpredictable. It rarely goes exactly the way that you want it to go. And so having this mindset of, one, coming from a place of understanding yourself, and then showing up into your birth space knowing that, hey, this is what I want. This is who I am. And how that applies to changes that may need to happen throughout my birth process will affect how you feel about the interventions that are happening, and how you relate to the providers in the room. And that, I believe, sets you up for the best kind of experiences when we are all working together as opposed to against each other inside of a birthing space. So now I'd like to move on to mental preparation. I know I'm just like winding on and on.
You
and
go, girl.
So mental preparation is really important. And so I did a lot of hypnobirthing in my first pregnancy, and a lot of mindfulness meditation. I prepared for a out of hospital natural birth, unmedicated. And part of how I was going to mentally prepare was through mindfulness. And I think this is actually really important because I practiced mindfulness throughout my pregnancy. And even though I ended up in the hospital with an emergency cesarean section, those practices helped me get through some of the harder parts in my delivery process. I'm claustrophobic, and I remember being in a closed MRI.
Oh, gosh.
And I used mindfulness techniques to get me through that MRI without having the panic attack that I was on the verge of having during that time. So practicing mindfulness as early as you can in your pregnancy, even if it's just 5 minutes a day or 5 minutes when you remember. You can practice mindfulness when you're brushing your teeth, focusing on the sound of your toothbrush. Or I had a trauma coach tell me one time, Kristen, stand like a flamingo while you're brushing your teeth, which may not be feasible for everybody, but you're really not thinking about anything else when you're focusing on brushing your teeth and also keeping your balance. But this will also prepare you for the marathon.
Interesting technique.
It is an interesting technique. There were a few other things she had me try too that really worked. Oh, the coffee, when you make coffee in the morning, just listening to the sound of the coffee. And if your mind veers off and starts thinking about what you're going to do in the day or whatever comes next, that's okay. That is part of becoming like more mindful and recognizing those thoughts, letting them drift away, and then focusing back on whatever your main focus is. It helps me to have some sort of music or guided meditation or a sound to kind of tune into as I am practicing this.
Which these are all things for preparing for pregnancy, but could work really well postpartum too.
Yes.
Yeah.
Yes, postpartum, when you have a new baby and you and your spouse are trying to figure out how to take care of this.
The rage hits.
Yes, the rage hits, and your spouse doesn't understand. Then you got this new baby you got to care for, and and you may have kids at home too, which that's a whole other thing. So mindfulness helps keep you patient and helps you navigate through the tougher times. But I think it's really important here because birth is a marathon without a predictable track. So athletes who sign up for marathons, they know where they're going. They know the exact obstacles that they're going to hit on their path. Whereas when you're walking into the birthing experience, or even pregnancy in general, you don't know where this marathon is going to take you. You don't know what obstacles you are going to face during this journey. You're okay. And so being able to mentally cope and find space within the birthing process will help you get through it to the other side with more mental, I want to say like mental wholeness, than as opposed to walking through this process without any coping mechanisms or without a support team to get you from point A to eventually point B. Let's see. I think that, do you have anything else that you would like to add to preparing yourself for birth?
We will eventually, in the series of classes, have childbirth educators and different people, different types of classes come in and speak. We're hoping to have a wide range of people that eventually attend the meetings, as far as like expecting parents that are birthing in hospital, out of hospital, whatever. And so one of the really important things that I have learned over the last 15 years with clients is taking a class that prepares you for a range of experiences and not just taking the class that's for out of hospital birth or the class that's for a medicated birth, right? Like I think back to my first pregnancy where I knew literally nothing. I was not a birth worker. I had no idea anything about birth. But I look back at that and I think I'm so glad that I didn't want an epidural, because that birth could have been very, very difficult for me had I wanted an epidural, because I labored so quickly that I couldn't get one, even if I wanted one, right? And so I think about that and I'm like, well, you really need to prepare for any situation. It's not just like these people that want everything natural that need to prepare. It's the people that want everything medical that need to prepare too, because sometimes you arrive to a hospital and it's hours before you can get pain relief. You have to get labs, you have to get fluids, you have to get the right person in the room at the right time. And so just taking a class that prepares you for every type of situation, even if you think it's not what you want. I've had a client in the past 2 years who started off taking a birth class that was very much geared for out-of-hospital birth. It was all focused on natural labor, avoid induction, avoid intervention, and then she developed preeclampsia at 32 weeks. So we start seeing a higher level of care and doing co-care, and we had to plan a hospital induction at 37 weeks for a first-time mom, which can be quite difficult. Not always, but it can be very difficult to get into labor through induction at 37 weeks. So the class actually did her more harm than it did good, because she came in with this mindset of, but I need to avoid induction in order to have this birth. And I'm like, no, okay, we're cutting off the class. And now let's sit down and talk about what of these interventions are actually going to help you, not hurt you. And so taking a class that was more balanced would have been better for her. She did end up with an induction at 37 weeks that took us 3 days, and we still got an unmedicated birth. No pain meds, no nothing, vaginal birth. Like, it was great, but it was hard. And it wasn't what she originally anticipated. So just having, education in every single facet is what's helpful, so you're not afraid.
Yes, and coming at this from like a neutral perspective, interventions are tools for you, whether they're natural out-of-hospital interventions or they're in-hospital inductions, epidurals, C-sections, whatever the case may be. They are tools to help you get from, again, point A to point B. And sometimes, if the goal is a vaginal birth, you may need an intervention to get you there, because that's the person you are. For Jamie, an epidural wouldn't have gotten her to the vaginal birth that she wanted, because everything was happening so quickly. But maybe for somebody else who has spent all their energy and is mentally on the brink of suffering, an epidural will give them the relief that they need to be able to achieve that vaginal birth. And there are many other examples for this as well, for all types of interventions, but coming at this from the perspective of these are all just tools that I can use, and they all have pros and they all have cons. And it's important to talk with my provider and understand my body, my specific health situation, to understand what is going to be best for me individually. I think is like key point there.
Yeah, no, I agree. And I think it's important to, if you have like somebody to help you, either whether it's a doula, your partner, a family member, or whatever, like, because it can be really overwhelming whenever you're trying to get all the knowledge and know this and know that and go to all these classes. It's like having somebody else there who can also maybe see it from a different perspective and maybe remember things that pregnancy brain won't rember, you know.
Yeah, the labor lands. Totally go in a different place.
Yeah, so it's like they'll know what your plans and wants what you may want, but then they'll also know like, okay, these interventions are also available and can be there to support you through that. So
yeah, I mean, I've had a lot of births myself, not just as a midwife, but my sixth baby, I did get an epidural with her at the very end, and I will never forget being so frustrated that I had to somehow think rationally, because my people in the room that were there to support me were like, you're Jamie Hinton, you don't get an epidural. What do you mean you want an epidural? And I was like, I've never had an epidural, but I need one now, guys, now. And so they were very like, what do we do with this? And I had to figure out how to come outside of my labor brain and tell them, like, look, I know how I labor. I've been doing what I'm doing right now for the last 8 hours, and my pelvis is like feeling like it's splitting in half. It's never been that way. I'm telling you, the baby's not in a good position, and unless I get an epidural, this isn't going to happen. And so having to like get those words out in a way that convinced people made me so angry. I was like, why am I the one having to explain this? But that epidural is really what led to a VBAC for me. I had a C-section with the fifth. Without an epidural, I was put to sleep. So that explains that. But the VBAC would not have happened had I not had the epidural. I got the epidural, and within like 45 minutes was ready to have a baby. And I had been at the same place for hours and hours and hours and hours. And she came out straight, face up, OP with a cord wrapped twice, like neck and body. And so I fully think like she was trying, and I just could not get everything to relax enough to let her come down enough until I got the epidural.
Yeah, and don't be afraid to advocate for yourself. And don't be afraid to get your partner involved. Actually, do get your partner involved. Have them read a book called The Birth Partner by, it's Penny Simkin, right? Yes, the founder of Donut International. Get your birth partner involved, because when you're in labor la land, as we like to call it, you need someone there that is going to, one, remind you of what your goals are, and two, help advocate for you, know what your wants and needs are, and also be able to adapt and change as you are adapting and changing, because it is very hard to be able to come out of this state and say, no, this is what I need because this is what my body is telling me. So having someone that knows you and understands that and can advocate for you, saying, no, this is what we need to do, will be very beneficial and help you feel very supported throughout the birthing process.
Yeah, agreed. Any more topics for the foundations of pregnancy that you needed to?
I don't think so. I think that was all. Yeah.
Okay.
Do you have questions or comments or anything so far? Audience of two.
Audience of two.
Come on. Fielder, how are you feeling?
Very sleepy.
Oh, goodness.
All right.
Okay, so I'm just going to cover the different providers that's available, and it's just really going to be just a quick overview, because our next class we will actually have these providers here to speak about their roles, and so they'll go way more in depth and cover everything. But so I'll just start with, obviously everyone knows an OB, doctor, and obstetrician. So that's typically a medical physician, pregnancy, childbirth, women's reproductive. They can do all those things. Typically they have went to school, gained the medical degree, typically minimum of like 12 years of schooling. They go through residency, all these good things. And they can care for you prenatal, they can care labor, delivery, and postpartum. And they can also perform surgical procedures such as like a C-section, or if you were in need of an emergency hysterectomy or something of that nature, an obstetrician can do that. And then you typically will find them, they work at hospitals, clinics, and they have their own private practices. And we are aware of maybe some that are interested in moving into the home birth field. So there's also some that could also be working in the out of hospital settings.
Yeah, I took a doctor to a home birth with me 2 weeks ago.
Yeah,
I think that's so cool.
That's exciting. That's actually really exciting.
I know.
Excited about coming out of the hospital. I was like,
Yeah.
all right, come on, and you can watch a birth.
Yeah, I think that's actually going to be great.
It went so well.
So be on the lookout for those. And then even
I said it's crazy, but
yeah, I know. And then even like above, well, I don't want to say above, but like next, like with an obstetrician is a MFM, which is a maternal fetal medicine specialist. And they basically a physician, but they have advanced their education with maternal fetal medicine. So they typically care for high risk women in pregnancies, like examples, if you have conditions that have developed during pregnancy, or if you had pre-existing conditions, if you have multiple babies, you're pregnant with twins, or if you had any fetal complications before. Oh, I thought that was mine. I was like, oh no.
You're good.
Yeah, that would have been terrible. So they any kind of complications you would typically see a MFM versus just an OB, and then obviously they're also in hospitals, and then they may have like their own private practice or clinic. And then we have midwives. So we have two different midwives. We have a certified nurse midwife, a CNM, which is a registered nurse that went to school to become a nurse and advance their education in midwifery. So typically like 6 to 8 years or about something like that. And then they can care prenatal care, labor, delivery, and postpartum and women's health. But they do not perform any kind of surgical procedures like physicians would. And they are working in hospitals, clinics, and they also work in birth centers and out of hospital births as well. And then we have the licensed midwife, which is LM. Some states here in Texas, they also have a certification CPM. Not everyone will have that certification. I think that's kind of like an optional thing, but licensed midwife is what they are. And they are trained typically through NORM or I guess it's like a midwifery school, apprentice type midwifery school. And typically maybe 2 to 4 years or so education, and then the services are prenatal birth, normal labor delivery, normal prenatal care, and postpartum care. And they can provide a well newborn baby exam, but typically your newborn will go to a pediatrician postpartum.
Yeah, we refer to pediatricians, and the client makes the plan with the pediatrician of when they want to see them. But we will still see the baby through 6 weeks.
Through 6 weeks. Okay.
And then the CPM, LM. So in Texas, if you get your CPM through NARM, then you become an LM through the state of Texas. Mm-hmm. But you don't have to continue your CPM. You can drop that and still remain an LM.
Mm-hmm. Okay.
So most midwives you'll see, out of hospital midwives, will say that they're CPM, LM, and then maybe down the road just LM. Like I'm now just an LM. I did not renew my CPM.
Mm-hmm. Mm-hmm. Okay. And then typically LMs are birth centers and home births, but they can have hospital privileges. Like Jamie is awesome, and
I don't have hospital privilege, but I do co-care.
But
do co-care.
Yes, you do work. I mean, you have worked with or have good relationships with the
with MFMs, OBs, and CNMs, so that you can collaborate care together, but the LM cannot do deliveries in the hospital in Texas. Right now, as far as I know, there's nothing saying that they can't. It's just that there's no hospital that is giving privileges to licensed midwives at this time. I do think in a few states in the United States that is happening in a few places.
I've heard of that. I've heard of that too. And just to clarify too, when we speak about licensed or certified professional midwives in this context, this is specific to the state of Texas. So across the United States, this section of midwifery is going to be different depending on what state that you live in. The regulations, education, and scope of practice will be different depending on the state that you live in. So it's important to look at your state's regulations and qualifications for licensed midwives or certified professional midwives.
Yeah. And then just, I guess, another person to be aware of, there are lay midwives or birth keepers that are in communities. They're technically not like licensed as a midwife or a provider, but they are in communities. So I just think it's important just to make sure whenever you're searching for a provider that you do your research on their credentials, on their scope, and just that you educate yourself when choosing a provider, and know if you have been pregnant before, or if you have any conditions, if you're low risk, high risk, or what kind of physician you would need, because maybe you can't do an out-of-hospital birth and you wouldn't be able to have a midwife and you would need an OB or MFM. So just do your research whenever it comes to different stuff like that. And then just another thing for the out-of-hospital providers, they're not required to hold the malpractice insurance, but some do. So it's just important, again, do your research and just check with them. They typically can provide that information to you.
And I think that helps, like, understand, again, coming back to understanding like your needs and your values when you're coming to a pregnancy and birthing space. What do I value in a provider? What sort of safety nets do I want in a provider? Are all going to be things that help you pick out who's going to be the best provider for you personally.
Yep, agreed. Do you want to add anything else?
In the state of Texas, if you are seeing a licensed midwife, you're supposed to be getting an informed consent, informed disclosure document at your first appointment that's gone over by the midwife with you, and it will actually tell you whether they have malpractice insurance or not. There's a line on there that you're supposed to initial saying, yes, I know that you do, or yes, I know that you don't have malpractice. And there's also supposed to be a conversation at that appointment and filled out on the paper of what hospital arrangements would be if you were to transport emergently without calling an ambulance. And that anybody in the room can call and go emergently to a hospital, but where that plan would be for, so that in the moment you're not trying to come up with what hospital is close to you. So there are things that are built in through the state that are supposed to help make this more transparent to consumers over what the person that they're hiring has as far as certifications, number of births, any issues that they've had, things like that.
Okay. All right. Well, that's all for the different providers. And then now, Jamie, you can do us the honors, kind of going over transfer and transport and levels of care.
Okay, cool. Let's do it. All right, so there are several different places that you can have a baby, and so far we've just clarified out of hospital and in hospital. But even within those two worlds, there are differences in facilities. So home birth is just home birth, right? So that's your home. The midwife is coming to you. Most people, when they start pregnancies with their first baby, they're like, oh, I could never do a home birth because that is like, they have nothing there. I think most people imagine it to be boiling a pot of water on the stove and the midwife like sitting in the corner knitting, which may happen, but it also may happen that she has a bunch of stuff with her behind the knitting, that has like her resuscitation equipment and her medications and things like that. But I think in general, people's idea is that a birth center is safer than a home birth, when in reality, most birth centers and most home birth midwives have very equivalent equipment and capabilities. Birth centers, there are differences within those as well. There's accredited birth centers, and then there's non-accredited birth centers. The accredited birth centers tend to have more restrictions on them about what type of births that they can provide. So doing like a VBAC, a vaginal birth after a cesarean, for the first VBAC, if somebody's had a cesarean with the first baby and wants to VBAC with the second, most accredited birth centers cannot do that. Non-accredited birth centers can. And so again, it's not that one is better than another. There's reasons why the accreditation says, no, we can't, we're not providing this. And so researching and figuring out why and what that may mean can help you pick the best place for you. There's also a lot of differences between hospitals, which I don't think most people realize either. They just think a hospital is a hospital is a hospital, and they can all do the same thing. And they cannot. They all have different levels of care. And so in Texas, our levels are level 1, 2, 3, and 4 for maternal care. And then for NICU capabilities, there's also levels within the system for that. So in Texas, for a level 1 hospital, you're basically getting the basic general services, right? So they do not always have anesthesia on call 24/7. Well, we don't have anesthesia on call 24/7 at home, and we also don't have anesthesia 24/7 at birth centers, and so that level 1 hospital is only able to provide a little bit of a step up from your out-of-hospital birth capabilities. So when I talk with clients about, like, here's where you live, here's the hospital's close, here's where I recommend going, it's not the closest hospital, but here's why. It's because the hospitals that, if we're transporting from home, most of the time I'm not wanting to go to a level 1 because they're not going to be able to do much more than what we were doing at home, right? They will have extra, like they can call in an anesthesiologist. The anesthesiologist has to be there within 20 to 30 minutes. It depends on which hospital system they're working for. But if we're going to need an emergent C-section, 20 to 30 minutes is still quite a bit of time to get somebody to the hospital. And that's assuming that that anesthesiologist is leaving the home right when the midwife calls the hospital and says, here's what we need. And oftentimes they're not doing that. They're saying, we don't know if they know what they're talking about. Get her here, you guys assess, and then let me know. And now we've delayed it even more, right? So level 1 is okay for people who could otherwise possibly choose home birth or birth center birth, or maybe has small risk factors, like if somebody has gestational diabetes, but they're diet controlled, but they don't want to be out of hospital, which they can be out of hospital diet controlled GD, but they don't have to be. So if they want that, then they could be level 1 hospital. But if that gestational diabetic mother is on insulin or metformin or glyburide, your 3 medication options, then she's probably going to need a higher level hospital, or want a higher level hospital, level 2 or level 3, because you have a greater chance of the baby needing NICU admission for blood sugar issues or breathing issues. Those hospitals, level 2, 3, 4, they're going to have 24/7 anesthesia on call already there. You're not waiting on them to come in. They're going to have a pediatrician that's there at the hospital. They're going to have an OB that's at the hospital. They may have CNMs that are at the hospital. So you've got multiple resources already there. That's for level 2. Level 3 and level 4 typically have more of the specialty services. And so if you have a liver issue, right, but you go to a level 2 hospital, they're not going to have a specialist that can come in and see you or maybe do a CT scan that day. You are going to have to wait until they're there. If you're at a level 3 or a level 4 hospital, they're already going to be there. The level 4 hospitals are going to be your top level babies that we know have conditions that are going to need surgical intervention after birth. I've had a client with a baby who had a diaphragmatic hernia. We don't know if that baby's going to need surgery within an hour after birth or within a month after birth, but we need to be somewhere where if it is an hour after birth, we can just go down the hall and do that. So that's our level 4 facilities. And most of the time those are connected to like large children's hospitals, right? Like Harris in downtown Fort Worth is connected to Cook Children's. So my client's baby with a diaphragmatic hernia, we had surgeons that we'd met with at Cook Children's. They came over from Cook Children's to Harris, like lots of collaboration there. If we'd birthed at a level 3 hospital, that baby may have had to be transported from the level 3 to the level 4 while the mom's still at level 3. So lots of things to think through that you may not always know ahead of time, but it is important to consider depending on your history and your baby's history. So we have a lot of really, really awesome hospitals in DFW. A lot of them get really great reputations for being welcoming for out-of-hospital birth. I know when I was pregnant with number 5, I think, there's so many.
So many.
But one of them that I was like, oh, I think maybe I would like to do this hospital because really great reasons. The view is so pretty out of those windows, man, like the whole wall's got the windows. But it was a level 1 and they didn't have NICU capability there. They didn't have 24/7 anesthesia there. Things that I was higher risk for needing because of blood pressure problems and being on insulin for the pregnancy. So I therefore chose to go to a different level hospital that wasn't as pretty, but it did have really great providers and really great nurses that took really great care of us and was able to help the baby when the baby needed help. So,
Yeah.
All right, what else was I supposed to talk about with that? I got off course. There are also, opportunities. I've said quite a bit about co-care, but haven't really explained that in depth yet. Midwives out of hospital and CNMs both can do co-care with OBs and MFMs. And pediatric surgeons and all these other modalities if they're needed. OB-GYNs can also do higher level referrals and co-care with MFMs. So it gets a little bit confusing because when we think about going to an OB-GYN, we think, oh, high risk, they do high risk. And they do, but they also refer to MFMs for even the higher level cases that they would like help with management on, right? So some of why that's done is because the amount of times that you're seen throughout pregnancy changes depending on your risk factors. If you are very low risk and you've had no complications, you're not coming into the pregnancy with type 2 diabetes or with chronic hypertension or conditions that would already risk you out of low risk care, you will be seen by your provider, whether that's a CPM, LM, a CNM, an OB, whoever you're going to, you'll be seen every 4 to 6 weeks throughout the 3rd trimester. Like starting at 28 weeks, that changes. But the guidelines say every 4 to 6 weeks. On average, people are seen every 4 weeks. If you're with a real busy office, sometimes they're like, we don't have availability, I'll see you in 6. So then you just have to figure out how you feel about that, which is another thing to consider when you're picking your provider, right? If you're using an out-of-hospital midwife, you are likely going to be seen more often because they have more availability in the schedule because they're not dealing with insurance all the time that's dictating how fast their appointments have to be and how many people they have to see in a day. If you're going to, I went to a CNM office for a few of my pregnancies that were higher risk and I did co-care with the MFM, and the CNM office could only get me in every 6 weeks and I was high risk. And so just figuring that out as well, because that also influences how much care you're getting. But the typical schedule is 4 to 6 weeks through 28 weeks. And then at 28 weeks, that's your 3rd trimester. It's every 2 to 3 weeks. And then at 36 weeks on, it's every 1 to 2 weeks, low risk. Then if you move up to the category where you've got chronic hypertension, you've got gestational diabetes, you've got any condition really that means that the baby is at higher risk of having complications during the pregnancy, then you will start doing weekly appointments for biophysical profiles and non-stress tests, which are sonograms and monitoring. Some places start those at 28 weeks, some places start those at 32 weeks. It depends on your particular condition or your baby's condition, what that schedule is. That's not a full prenatal appointment. That's an appointment where you go in for the fetal well-being, and that's it. You'll still see a provider every 2 weeks at that point, and then every 1 week at 36 weeks on. So those are some of the differences. The co-care that we do, not every midwife will take people who have conditions that risk them out of home birth or birth center birth, right? Like some of our CNM groups, like Midwife and Co., they don't always take people who they know you're going to need a C-section, because the OBs are who do the C-section, they will just refer them on. but other midwives will. Like there's a group, I'm so much more familiar with the Fort Worth side of things, so not much of the Dallas. You maybe. Does Diana Health take people like needing scheduled C-sections and whatnot?
Sure.
Okay. Do you have any idea who else, like what other midwife groups take scheduled C-section clients?
Technically, I do through my nonprofit.
Okay,
So yeah.
cool. All right. So I know like Texas Health Physician Group, nurse midwives in Fort Worth, they do take people who need scheduled C-sections because they have physicians in their office that they can just be like, okay, we do all this prenatal care, we'll come to the birth, to the C-section with you, and they first assist. Out of hospital, some of us do and some of us don't. So Mosaique's nonprofit does. I do. I take people in the office. I know they need a scheduled C-section for whatever reason, and I just see them for prenatal care, and then we go see the maternal fetal medicine high-risk specialist for whatever the condition is, and we schedule the C-section from there. So lots of options. It should.
Wellness, I think.
What is it?
Dallas Women's Wellness.
Oh, cool. Is that at
Patriot Group.
Presby Dallas?
Dallas Presby.
Okay, yes, Dallas Presby, they do as well. So lots of options. You just have to find the particular model that you're looking for that fits for you, that also is going to provide you with the location for your level of risk.
All right. Well, that's technically the main topics we were going to talk about. Controls. Yeah. Did y'all have any questions about anything that we discussed, or any other questions
Or topics?
or topics?
No?
No.
Okay.
Okay, so our hope is that we will have full meetings. We like the idea for this kind of grew out of what used to be Tarrant County Birth Network. Did y'all ever go to those? TCBN? Okay. TCBN was really big back in its day. And so it had providers from in-hospital, providers from out-of-hospital, consumers, and that's what we're hoping to grow this into, to give non-biased information and so that people can make good decisions and know that they're cared for. So we would love for people to share and invite friends and colleagues and whoever so that we can have great meetings.
Yeah.
Yeah.
That's the goal. Well,
excited.
yes, thank y'all for coming. We look forward to the next meeting. We'll be